Hi, everybody. Welcome to this informational webinar on the Social Interventions Research and Evaluation Network's call for proposals. I'm Laura Gottlieb, and I'll be joined today by Caroline Fichtenberg. Caroline and I work with Nancy Adler at the University of California, San Francisco, where we direct the SIREN program. Before I describe our work with SIREN, I want to just go over a few webinar logistics for today's conversation. So first, the webinar listeners are muted to maintain call quality. To ask questions, please use the chat feature on the left side of your screen. Additionally, the slides and a recording of the presentation will be available on the SIREN website following today's conversation. So to get started, I want to officially introduce the Social Interventions Research and Evaluation Network. This is a project housed at the University of California, San Francisco, and funded by Kaiser Permanente and the Robert Wood Johnson Foundation. SIREN's aim is to both disseminate and catalyze high-quality research to advance efforts to address social and economic determinants in the context of healthcare delivery. So I'm going to take a few minutes to just describe why we founded SIREN. It's no secret that over the last few years, there's been a very big increase in the buzz focused on the role of the healthcare sector in addressing patients' social determinants of health. The experiments we've seen have included everything from activities focused on community engagement and political advocacy to encounter-based, patient-focused efforts to identify and address social needs in the context of clinical care delivery. That healthcare delivery-focused work has in large part come about because of two things. First, over the last 2 decades, there's been an enormous increase in the amount of research on the connections between social and environmental determinants and health outcomes. And second, that connection is intuitively obvious to providers of healthcare services, especially in settings serving low-income patients. I'm assuming this cartoon will resonate with many of you who are listening today. But there are a lot of different ways that healthcare delivery settings might use information about patient social and economic risks to shape the delivery of care. So first, they might use social determinants data to modify the traditional care provided in healthcare settings. These are things that we often do in a safety net, though we don't do it well. For instance, we might dose medications around people's work schedules, we open evening or weekend clinics, we use non-refrigerated medications, we include interpreters in care delivery, we use phone or text instead of mail reminders, all ways that we modify traditional care. Another option that pushes up against the bounds of clinical care delivery is that healthcare actually begin to include services directly aimed at changing patients' social determinants. This might involve helping patients connect with food programs to resolve food security, help them find a living wage job, link them with English as a second language programs, all with the knowledge that addressing social determinants could potentially be part of what makes high-quality healthcare. This second area is the space where we at SIREN are focusing our efforts to better understand the existing evidence and to catalyze new research. Though this work involves a bit of a paradigm shift for the medical care system, there are already many organizations now working in this space, including many major medical providers in states and medical professional organizations and influencers like the medical professional organizations and influencers like the National Academy of Medicine, the National Association of Community Health Centers, primary care associations across the country. The list on this slide is in no way exhaustive, as many of you probably already realize. So based on the work of many of these innovative organizations, we've seen a tremendous growth in interest and experimentation in this field, in large part focused on primary care, where innovation has been ahead of the curve. Despite this amount of innovation and experimentation, evidence on what actually works to improve health for patients has lagged. Just to drive home that point, this slide shows the results of a literature review that we conducted through SIREN this past year, showing the tremendous growth in literature being published in this field. The dark blue bars show the growth in literature published just containing the word social determinants of health. The green bars show literature published that was related to social determinants of health and healthcare specifically. So we're seeing upwards of 400 articles per year being published related to social determinants of health and healthcare delivery. But then we looked for articles related to social interventions conducted in healthcare that involved some form of evaluation. And this is where you see these tiny red bars now added to the graph. Since the year 2000, we identified only 67 articles published evaluating interventions in this space. And of those, very few would have been considered high-quality evidence upon which to base action. More than half of those articles looked only at process outcomes or the effectiveness of the intervention at impacting social determinants outcomes. A much smaller number examined cost or utilization outcomes. As a result, we worked with Robert Wood Johnson Foundation and Kaiser Permanente to develop this call for proposal that focuses on evaluations that will look at healthcare cost and utilization impacts. I'm going to turn it over to Caroline to present the call for proposal.
Thank you, Laura. So as Laura mentioned, what we're trying to do with the SIREN Innovation Grants is really help develop high-quality evidence about the healthcare cost and or utilization impacts of social and economic needs interventions in clinical settings. So we want to fund evaluations that would help determine the impacts on either healthcare costs or utilization or both of interventions that address social and economic needs as part of clinical care. Now there's a lot of discussion about social determinants of health and what those things mean and a variety of ways of defining them. We're talking here about any kind of social and economic hardships that impact health outcomes, things like food security, education, employment, safety, social support, transportation, financial security, housing security, housing quality, and these are just examples. There are other factors and other social and economic hardships and needs that can be addressed in clinical care or in partnership with often other organizations as part of clinical care. So we are looking for interventions that address those needs, and we want to look at interventions, we want to fund evaluations of interventions that look at healthcare cost or utilization impacts. As Laura mentioned, there have not been that many evaluations of these kind of interventions to date, and many of them have looked either at process outcomes, like how many patients are seen, are provided with services, and some have looked at health impacts, such as impacts on blood pressure or other health outcomes. And we're particularly interested in funding evaluations of interventions that look at the healthcare costs or utilization impacts. So these can be things like the costs of the intervention as compared to the costs or savings for patient health care, or things like changes in patient healthcare utilization patterns. Sometimes that can be things like well child visits in a pediatric setting, or emergency department visits if you're looking at high utilizer complex care type situations. But these are just examples of the kinds of outcomes that we're interested in. In terms of the grant details, the hard numbers here, we are looking for applications for grants up into $150,000. And we realize that that's not enough money to do a whole new intervention and evaluate it. So what we're thinking about with these grants is that there are opportunities to leverage other funds and to hopefully add on an element to an existing study to enable the collection or analysis of cost and or utilization data. That's what we're thinking about, but we're open to any kind of proposal that comes in at $150,000 or less. Grants can last up to 2 years, and we're anticipating making something around 4 to 6 awards. In terms of our timeline, letters of intent, we are asking people to submit letters of intent by May 15th. To let us know that you're planning on applying, and this just has to tell us that you're going to apply and who you are so that we can plan accordingly for the resources we'll need for the reviews. And then the full proposals are due June 15th, and we anticipate making awards starting on or after September 1st. In terms of eligibility, preference will be given to tax-exempt organizations, and we do require that organizations have to be based in the U.S. or a U.S. territory. We will be selecting the finalists based on 3 main criteria. The first will be significance, or the potential of the proposal to add to our understanding of the healthcare cost or utilization impacts of these kinds of interventions. The rigor of the proposed study design and the potential of the project to generate high quality evidence. And for that, we're really looking for study designs that have some kind of a control that enable a reasonable sense of the impact of the intervention. And third, we're going to be looking at feasibility, the qualifications of the research team and the feasibility of the project within the time and budget proposed. How to apply, again, we are requiring a letter of intent by May 15th. You just have to include the name, contact information, and the organizational affiliation of the PI. There won't be any selection based on the letters of intent. It's just for informational purposes. The full application is required by June 15th, and the information about what needs to be in the application is on the website. There's a proposal format. We would like a budget and a budget narrative. And the proposal narrative needs to be at maximum 6 pages. And all of these will be submitted via email to siren@ucsf.edu. And that concludes our presentation part of the webinar. We wanted to make this nice and short so we have a lot of time for questions. So we're going to start with questions. And Stephanie on our team is going to be reading out the questions for us to answer.
Great. So the first question that we have submitted is, do the interventions need to already be shown effective in changing other types of patient outcomes?
This is Caroline, and the answer to that is no. To the extent that the proposal can make a convincing case that there is a reasonable expectation that there would be some health care and cost impacts, it doesn't have to be an intervention that's already been proven effective in terms of health impacts. Laura, do you want to add anything to that?
No, I agree.
Great.
Great. Another question that was submitted is, what is the preferred methodology for measuring cost?
So I'll take that. So no preferred methodology. We've spoken with people who are interested in cost effectiveness studies, cost benefit analyses, and others. The important piece is just to make a case for why the methodology that you're choosing is the best one for studying the intervention that you're looking at.
Great. The next question is kind of a broader question about the eligibility of organizations. So what would constitute a healthcare setting? So in this case, it's a community peace center that has traditional healthcare providers on site with 2 different hospitals as well as mental health providers.
So Erin, I would say that it's a good question, I think relevant probably to many of the people on the call. If the intervention is being provided in the course of care delivery, so in the context of there actually being healthcare delivery, whether the healthcare delivery agents are working within another organization or in a specifically designated healthcare delivery organization, it doesn't matter. But the intervention needs to be connected to the healthcare delivery activities.
Great. And then we have several questions about the measures. So would you consider quality improvement projects to fall under your definition of an intervention?
This is Caroline. Yeah, I think that's a very good question. I think that potentially yes. I think depending on what kind of quality improvement intervention you're talking about. I think if you're talking about a quality improvement effort, we're most important in better understanding the impacts of, again, interventions that help address patients' social and economic hardships. If there is an intervention to do that is being implemented as part of a quality improvement effort, then I think yes. I think just evaluating the impact of quality improvement to an existing intervention wouldn't necessarily qualify because you wouldn't be evaluating the impact of the entire intervention. If that doesn't quite answer your question, feel free to follow up. And Laura, do you want to add?
I'll follow up. Yeah, I'll just add something, which is, Susan, it's a good question. I think most quality improvement projects are not incorporating rigorous study designs in evaluation. So I think we'd want to see how the collection of data is actually going to fall into, give us evidence that we can use reliably to generalize to other settings. So in as much as your quality improvement project is being designed with providing the service to some people and not providing to others and collecting data from both, or using some other similar rigorous study design, I think that it could work. I haven't seen a lot of quality improvement projects that are designed in that way. I hope that's helpful. Don't hesitate to reach out if that doesn't answer your question.
Great. And then we have a couple of questions just asking, do the outcome measures have to include both healthcare utilization and cost, or is it fine to do one or the other?
It's fine to do one or the other.
Great. And so kind of a follow-up to that, do the interventions need to show clinical outcomes, or do they just need to show overall utilization and or cost impacts?
We're okay if they just show utilization or cost. These are all great questions.
I'm going to jump in there for a moment, Steph, before we move on to the next question. This isn't a ton of money, and we're quite aware of that. But one of the things that we've noted in other grant programs that we run at the University of California, San Francisco, is that many successful applicants have been able to use even small amounts of money to add on to an existing study that perhaps isn't looking at these particular outcomes. And so I would encourage our listeners and other people who may be listening at other times to this webinar or reviewing the notes that thinking about how to add cost and utilization outcomes onto other studies that perhaps are getting external funding, kind of leveraging that funding in order to just add these additional pieces might be an effective, might make for an effective application just because the amount of money isn't huge. It's not enough to design your own randomized control trial, but it may be enough to add a staff person or to collect some measures that you weren't able to add into your original study.
Okay, so moving on from that, can you provide some examples of clinical interventions that would meet the grant criteria?
Caroline?
Yeah, sure. So a lot of interventions in this space tend to be interventions that will screen patients for either one or a few needs or for a variety of needs, and then connect them with community services or provide services on site. So some examples are interventions maybe that will screen for food security and help connect patients who have issues with food security to local resources like food banks or organizations that can help them sign up for federal food benefits or make access of, get access to benefits, or interventions that screen for a range of needs and then have a member of a care team, sometimes a social worker, sometimes it's a community health worker, navigator, care manager, depending on the needs of the patient, help connect them with local resources. Sometimes there are resources provided on site, such as the example of medical legal partnerships, where lawyers can be available to help patients who may have legal challenges, either relating to access to benefits or any legal aspect that could affect a social determinant of health. There are also other types of interventions that can provide needs, address needs directly on site. We've seen things like having food pantries on site to access food, or health systems that are partnering with housing organizations to provide access to supportive housing as part of transition out of inpatient care. So there are a whole variety of interventions. Laura, do you want to add anything to that to help paint the picture of the kinds of things that we're talking about?
No, I think those were great examples. Thanks, Caroline.
Okay.
And then we have a question. So what are the deliverables that you are expecting during the grant timeline or at the end of the grant?
That's a good question. The grant deliverables would be, conducting the proposed research and developing a written product of the analysis of the research results. I don't think that we anticipate that there would be something published necessarily within the 2 years, because we know that that can take time. And there's not, Laura, correct me if I'm wrong, we don't have a requirement in there that something has to be published as a result, since we know that there can be, that's not always within the control of researchers, but we haven't, the expectation is the research that is proposed is conducted, and that there is a publication that results from it that allows for learning from the research. Yeah, please.
I'll just add a couple of things. So 2 major deliverables. The first includes participation in a work-in-progress webinar with the Research Advisory Committee for the SIREN initiative, and that has to be done within the grant term, ideally at the beginning, near the beginning of the project, to get feedback from other people who are doing research in this area. And then finally, a final grant report is due at the end of the grant term. But otherwise, there are no specific deliverables. As Caroline mentioned, we are expecting that these projects will turn into published manuscripts, but that's unlikely to happen within the grant term.
Great. So are there any requirements regarding the qualifications or experience of the PI? For example, do they need to be a PhD?
They don't need to be a PhD. Stacy, thank you for the question. But they need to have shown that they have the experience necessary to carry out a study, and that can be shown by experience with other studies, leading other studies or other initiatives similar. And you can include that information in the CV of the investigators.
So this is a sort of related question. You've kind of covered the academic credentials portion of it, but would an embedded research team inside of healthcare delivery be eligible for the grant?
Absolutely.
Great. And then this one's also very related, but I just want to get them all together since they're related questions. Are local health departments who are working in partnership with local hospitals, SQHCs, or CHCs eligible to apply?
Yes. So the applicants can be either the local health department, the healthcare delivery agency, or even social service sector partners working in collaboration with the healthcare setting. The important part is that the data are available to show cost and healthcare utilization and/or cost and utilization outcomes. So the lead applicant can be any organization that has the capacity to lead this kind of research.
Great. Let's see. Would using a natural control group measuring outcomes of clients we are serving before and then after the intervention be considered rigorous enough? We don't have the capacity to do a traditional RCT.
So the answer is yes. So we will absolutely consider a wide range of study designs. It would be important in every application, to defend the type of study design, why you think it's the best study design to avoid bias, and what you think the research findings will contribute to the field. But we will consider any form of study, but it would be helpful to have you defend that study form in the application.
Great. I think you've already addressed this, but just so I make sure that Lisa's question gets answered. Can the planning have started already and be designed, or are you looking for a brand new initiative?
It does not need to be a brand new initiative, but it needs just remembering that the data will need to include cost and utilization outcomes, and explaining how you will get those for patients who may not have, if that information wasn't included in an original IRB, then you may need to go back to consent patients to collect that information. So just making sure that the application includes information about how, if it's not a brand new initiative, how those data will be accessible.
Wonderful. Can funding be used to support salaries of staff performing the screening or providing the services? For example, a nutritionist who does education and referrals and case management for food insecurity.
So, Misa, thank you for the question. Funding, there's no limitation on how the funding can be used. It could be used to support salaries. I think all of the listeners are probably acutely aware that $150,000, which is our maximum grant amount, and certainly people can apply for less than that, won't go very far for supporting salaries. So again, I don't know if you were on the line at this point, Misa, but we were encouraging folks to think about using this money as an add-on to an existing study when and if applicable, just because the funding, there's not a ton of money. If there were, it would be easier, I think, to support salaries. But in general, this will probably be most effectively applied to add an evaluation to an existing operation or existing program implementation.
I think maybe this question has already been answered, but just to make sure, should the evaluation include process and outcomes or either?
So
go ahead, Caroline.
Well, I was going to say, so the evaluation should include healthcare cost or utilization impact, or both if you want to, but it definitely should include one of those two outcomes. It does not have to include process outcomes or health outcomes. We really want to focus on the cost and utilization, again realizing that this is not a lot of money and we can't be asking for everything. So we're hoping that you can use this, as Laura has mentioned, to really focus on the cost or utilization or both impacts.
I would just add, I totally agree, and I would just add, I think it's an important question. It would be really difficult to do a study like this and not look at any process outcomes. So by process outcomes, we're referring to things like the number of patients screened, or the number of positive responses to those screenings, or how effective the program was at connecting people with existing resources in a particular social risk domain. So it's not that process outcomes are not part and parcel of the work that's being done in this field, but rather that we're trying to extend the work to include cost and utilization outcomes. So it would be, I think, virtually impossible to not include some process outcomes, but that's not the unique part of this call for proposals. So yeah, certainly include a list of any of the questions, any of the outcomes that you're interested in your proposal, but definitely make sure to include cost and or utilization outcomes, because that's one of the eligibility criteria.
Great, and this is related to an earlier question that was answered, but just because they provided a lot of specifics, I was trying to get to it. In terms of rigor, is a controlled group the only way to show impact, or is it okay to evaluate 12 to 24 months prior to intervention and use that cost utilization as baseline?
It is okay to use, as we mentioned before, it is okay to use a study design that you think is most appropriate to the population that you're serving and that will give us the best possible evidence. If it's not possible to have a control group, then thinking about how the study design that you select can best control for bias will be an important part of that application. But we will absolutely entertain applications that include other study designs, not only those with a control group. If it is possible to include some form of a control group, it would make for a stronger study design, but that's not always possible. So just defending the study design that you select is the most critical part.
And if I can just add one thing, I think one of the concerns in particular with a pre-post design and why what you want to try to address in terms of a limitation of that design is the potential for there to be changes that happen over time or regression to the mean that obscures the real intervention impact. So having a way to distinguish between that and the intervention impact and other changes that can happen over time is what we'd probably be looking for in that kind of a design.
Well, it looks like you've both answered the questions that people have asked so far. I just want to remind people, if you do have any questions, please enter them in the chat function and we'll try to get them answered. Otherwise, you can always send us an email if you think that your question is more specific to your project and not maybe generally applicable. Okay, we have another question from Nicole. What kind of scale are you looking for in the intervention? Is a single county or hospital appropriate, or are you looking for a more broad partnership?
So Nicole, a single hospital or county is perfectly appropriate. The application that includes an estimate of the power of that particular study to detect significant effects would be helpful to defend the study size. But in a single county or hospital, you may be able to recruit enough patients into the study that it would have significant power. So, just take that into account as you're submitting or as you're writing the application.
And then we have another question from Lisa. Is there a requirement for the number of people enrolled into the intervention? Are there also payer mix requirements?
No payer mix requirements and no requirements on the number of people enrolled. But again, I would just emphasize that including some sort of power calculation in the proposal would be really important to demonstrate that you think that the size of your study will be sufficient to be able to contribute to the literature. And you can sort of see, an application with 20 that says we're going to recruit 20 patients into the study may not have adequate scientific power to contribute to the literature in this field, although it may be very impactful on those patients.
I think we'll give people a few more minutes to ask some questions. And again, I just want to remind you if you feel like your question might be a little too specific for general education for others on the call, you can always email us at siren@ucsf.edu or connect with us via Twitter or any other way that you can find online, and we'll either answer your questions then or set up a time for you to talk with somebody from the program.
I certainly want to add just that we thank everybody for participating in the webinar, and we are both eager to take your questions via email and Twitter and other formats, but I also want to encourage folks who are using the website or learned about the CFP through the website to encourage you all to send us any feedback also that you have on the website or other resources or tools that would be helpful for us to include to people across the country and beyond who are interested in this growing field. So not only are we interested in your specific questions about the CFP, but also resources and tools that you think that would help you in your efforts to do better evaluation on the interventions that are being conducted in healthcare settings around the country. It looks like Erin has asked another question, Steph, that I'll just take. So, Erin, it looks like you had a question specifically about the intervention occurring during the provision of healthcare, and I just want to clarify that the intervention has to be initiated or part of the encounter with healthcare providers or with the healthcare setting or healthcare delivery setting, but some of the intervention pieces of it, in many of the examples that Caroline emphasized, actually include community partners. So oftentimes the social or economic need or hardship is identified in the course of care delivery, and then patients are referred to external partners and then come back to the healthcare delivery organization. So some piece of the intervention needs to be, or the need needs to be identified in the care of the delivery, in the process of care delivery. I hope that helps.
And I think the rest of the question, Laura, was around, I think that the intervention would take place during centralized intake process, and the client would then later be routed to the healthcare provider. I think part of the answer to that question would be the centralized intake process, in what setting that occurs. And we're happy, Erin, to talk more in detail about that specific case. I think that the type of intervention really we're centering on is really this idea of better integration of medical and social services. So to the extent that that the intervention is somehow taking place in a way that is integrating, that I think that would also likely be eligible. I don't know, Laura, if you want to speak to that a little bit more, or if we should just answer specific questions as they come, specific cases.
Yeah, I think, Erin, if you can reach out to us directly, I think we'd be happy to talk about that a little bit more. But generally speaking, we are looking for some form of integration between the health and social service delivery components.
I think this has been touched on already, but can the proposed intervention include episodes of care involving non-clinical providers but under the general supervision or oversight of a physician?
Yes, so many of the existing interventions around the country that we have incorporated under the umbrella of sort of SIREN type interventions are being provided by adjunct members of the clinical team, so healthcare navigators, advocates, peer support specialists, community health workers under the oversight or supervision of a clinician. So I think, Steph, if it's okay, it seems like the questions, we've mostly answered all the questions that have come up during today's call. It's an open invitation to everyone on the call and to others who you may know who didn't have a chance to participate today to contact us directly at sirenetwork at ucsf.edu. Steph, did I get that right? No, siren at ucsf.edu. All the information is right there on the slide and available on our website. But thank you all so much for participating in today's call, for your interest in the call for proposals, and we look forward to hearing from many of you. And please don't hesitate, again, to give us feedback on the website or let us know about other tools or resources that could be helpful to you in the course of your efforts to evaluate the programs underway. So with that, I think we'll end today's call. Thank you all so much.